Welcome to AETCM channel. And I'm a 61-year-old female, background-wise, who's a known case of VSD on medical management and a known case of hypothyroidism. Now she presented with the complaints of generalized fatigue since last 4 days.
Can you tell me something about VST, clinical findings of VST?
Clinical findings, patient, if along with any pulmonary hypertension, anything was there associated with that, patient will have this right ventricular hypertrophy and also.
What is a typical finding of isolated VST?
Pansystolic murmur in the lower left sternal border, like fourth intercostal space.
Can it be associated with any other murmurs? So you have a patient who is having isolated VST. That you are told pansystolic murmur will be there.
Yes.
Can it be associated with any other murmur when it becomes severe? The VST slowly will become severe.
Yes.
What will happen to the left ventricle after some times? In VST, what will happen to the left ventricle after some times? Ventricular septal defect. So what will happen to the ventricle? Hypertrophy or dilatation? Is it a volume overload or a pressure overload? For left ventricle, it is a volume overload. For right ventricle, it is a pressure overload. So what will happen slowly?
Dilatation.
It dilates. So when it dilates, what will happen to the mitral valve orifice? It dilates. It dilates. So what will happen? Mitral regurgitation. So most of these patients, after sometimes, they may be associated with a mitral regurgitation. What is Malady-Roger syndrome? You don't need to answer. This only medicine PG will answer. Because their exams it will be asked. What is Malady-Roger syndrome? So can you judge a VST on the basis of the loudness of the murmur? How do you judge the severity of the VST? Is it loudness?
Based on
it loudness?
No, so based on the size of the defect.
We don't know. No, we are clinically examining. Yes. In exams, you don't see the echo report. Afterwards, we'll show the echo report. So if you know what is Malady-Roger, then you will understand. Respiratory medicine PG also should know this. A small VST can produce a very loud sound. That is Malady-Roger. Okay. Very small VST without any left ventricle effect, that can produce a very loud sound. So loudness doesn't tell that the severity of VST. That is an important factor. Okay. So if you have a very loud murmur, it may be a small VST. But other collaborative findings, you have to see what is a left ventricular dilatation is there or not. MR is there, S3 is there. These are the severity index. Then later the patient present with pulmonary arterial hypertension and reversal of the shunt, cyanosis, all these things. Okay.
So basically she presented with generalized fatigue since last 4 days, and then along with that she had complaints of breathing difficulty past 2 days. This was gradually progressive, associated with orthopnea, and she have also chest discomfort was there, but no complaints of fever, no complaints of cough, no complaints of vomiting, no loose stools, no abdominal pain, no complaints of reduced urine output. But in past history, she had actually had toothache 2 weeks back. For that, actually she was underwent root canal treatment some nearby hospital, and they have prescribed antibiotics, like ofloxacin was prescribed, and she took for 2 days.
When will you give antibiotic in a suspected VST case? What antibiotic you prefer for dental procedures? These things are important. When you don't do this practice, patient will come back with infective endocarditis. So you will be a physician, you will be asked to give fitness for a dental procedure in a VST case. How do you give VST case fitness? For that, you should know what is infective endocarditis prophylaxis. Is it a high risk case or low risk case? VST is always an high risk case. because there is turbulence in the heart. That jet can produce damage to the ventricle. Infective endocarditis can be formed there. Okay. So how do you give prophylaxis? What prophylaxis you give for oral procedures? Is that ofloxacin is correct, and after procedure giving ofloxacin is correct? So it has to be given. It has to be given much before the procedure. So before the procedure, and it has to be something like amoxicillin, augmentin, gram-positive coverage has to be there. Okay. Ofloxacin is okay, but it is not a good coverage for gram-positive organism at all. Okay. So it may not work. Okay.
Like vitals wise, actually, pulse rate was 114 per minute. It was regular. BP was on the lower side, 170, and respiratory rate was high. Like tachypnea was at 28 per minute, and saturation on arrival was like 70% was in room air. Temperature like 98.4 degree Fahrenheit. And then, like general examination, patient was conscious oriented, afebrile, no pallor, no icterus. Cyanosis, like mild cyanosis was there under under surface of the tongue, and then
What is the saturation?
saturation 70%.
70%. So is it a reversal of shunt or something else?
Because cyanosis and hypoxemia was there, so reversal of shunt, ASM members will be under.
ASM members.
But no pedal edema present, no lymphadenopathy. So examination of cardiovascular system on inspection, trachea appears to be normal, no precordial bulge, apical impulse not seen, no visible pulsation, no dilated veins, no scars, no sinuses. Palpation wise, trachea appears like trachea is central in position. Apical impulse felt in the left fifth intercostal space, medial to midclavicular line, and then parasternal heave was present. Thrill was also present.
Parasternal heave means what?
Like it indicates right ventricular hypertrophy, like increased pressure in the pressure overload state in the right.
What are the types of parasternal heave? You know? What are the reasons for parasternal heave?
Right ventricular
hypertension.
So there are two reasons. One is left atrial enlargement. Other one like she told, right ventricular enlargement. So parasternal heave can be systolic or diastolic. Okay. So as a medicine PG, you are supposed to do all these things. Okay. So you have to learn all these things. What is a parasternal heave? Whether it is a parasternal heave in systole, diastole, or whether it correlates with your apical impulse. All these things are important. Then you can tell which chamber of the heart is dilated. Now we have echo. We don't depend on all these things. But examination, they'll ask all these things. Okay.
Then auscultation wise, actually, pansystolic murmur was felt in the left second intercostal space and then left fourth intercostal space also. No carotid bruit. And then other systems, respiratory system, normal vesicular breath sounds heard. Bilateral artery was equal, but bilateral basal crepitations were heard in the left infraaxillary and left infrascapular areas. Abdomen was soft, not tender, and no organomegaly was there. Nervous system, no focal neurological deficit was there. So basically, this patient, 61-year-old female, known case of VST and hypothyroidism, presented with generalized myalgia with past associated with breathing difficulty. The past history.
So you are telling it is a reversal of shunt.
Yes. Like findings. On findings.
So you think that this patient is having pulmonary edema? What is the reason for palpitation? What happens to the incidence of pulmonary edema in reversal of shunt?
Patient if going for complication,
pulmonary hypertension occurs. So from right ventricle, pumping is going to reduce because of the hypertension. So the amount of blood reaching to the pulmonary circulation is going to reduce. So what happens to the pulmonary edema or left ventricular failure in this type of patients? whether they come back with pulmonary edema or cyanosis due to the severity of the reversal of shunt. What is more possible? Is pulmonary edema is common in reversal of shunt or not?
Cyanosis will be common.
Cyanosis is there. That is because of the reversal of shunt. Other thing? Just imagine pulmonary pressure is more. It is blood is not going to enter like in a normal person. So the incidence of pulmonary edema as such is low. Okay. So because the blood is not going, but since there is a reversal of shunt, patient can have hypoxemia. Okay.
Basically, this patient initially, like the history and examination, thought of like might be like fluid overload or like a lower respiratory tract infection, but while proceeding with the investigations, like first initially like lab investigations was done, like CBC, CRP and all. It was like CRP was inflammatory markers were little bit high, like around.
Is there any peripheral signs of infective endocarditis?
Peripheral signs.
What are the peripheral signs of infective endocarditis?
Peripheral signs: osseous nodes, Janvey lesions, then splinter hemorrhages, and then in fundus rod spots.
Splenomegaly.
Splenomegaly.
Okay. So anything is there in this patient? Nothing is there. Okay.
So like then after proceeding with normal to transthoracic echo, in that actually we found vegetation was there in the pulmonary valve.
Okay.
So initially we have sent only like 2 blood cultures, but cultures were negative. But after seeing the echo, we just like sent like 3 sets of blood cultures. Aerobic and anaerobic cultures were sent from different sites.
Different sites in and
different
time.
Hourly.
12, not hourly. It is
24 hours.
12 hours
hourly,
apart you have to send each sample. That is very important. Why we are sending like that?
So, to bloodstream.
Okay, to prove that it's a bloodstream infection and it is a continuous flow of bacteria from the heart. Okay, that is very important. Okay, then
After that we have started on IV antibiotics. Initially itself, like she was started on empirical antibiotics, ceftriaxone, but after that actually, since we have found vegetation, along with the ceftriaxone, vancomycin also added.
What is the empirical treatment for infective endocarditis?
Empirical treatment in sense like we have to consider like both gram positive and gram negative coverage antibiotics has to be started, along with like MRSA. For covering MRSA also we'll be starting vancomycin.
Okay.
Usually ideal choice will be penicillin along with ceftriaxone for covering gram negative also.
Okay.
But if patient if we are suspecting MRSA, we'll be giving vancomycin.
Vancomycin. Okay. What are the cardiac lesions which are prone for highly prone for infective endocarditis?
Like regurgitant lesions.
All regurgitant lesions. Then
prosthetic valves. And then any
cardiac. Okay. Post and congenital valves. Which are the lesions which are less prone for infective endocarditis?
Stenotic.
Which are less prone for infective endocarditis? AST and one more. You told stenosis. What stenosis?
AS.
Yes.
Aortic.
MS and
AST.
Okay. In that ASD is the least, because MS also there is a chance of infective endocarditis. Wherever there is turbulence, there the lesions are very common. That turbulence will go and hit on the walls of the ventricle or atrium. There it produces some damage and infective endocarditis can be formed. Okay, that is a common thing. Okay. Now what happened to this patient after this one, starting the treatment?
After starting the treatment, her like inflammatory markers and counts and all was improving. So, but meanwhile, she developed AF also. Okay. So she was started on like amiodarone and then now reverted. Now actually patient is in CC. She's becoming better.
How do you manage AF?
AF like
What is the reason for AF here? What is the reason? Hypoxia is the reason. Here the reason is hypoxia. But since it is not going to reverse, that hypoxia is not going to reverse, you have to permanently treat this patient. If it is some other case, then if you correct the hypoxemia, it will become all right. Okay. How do you manage AF in a routine setup?
Routine setup.
This is not a routine setup. This is not going to reverse, and it is going to increase the problem. Okay. The AF itself is going to increase the problem. Okay.
Like first patient we have to look for like whether patient is hemodynamically stable or not. If stable means we can start on amiodarone infusion, and then followed by we have to give rate control also, and then beta blockers. And suppose if patient is unstable, cardioversion has to be done.
What is the ideal way of treating AF in emergency room? Rate control. So the ideal way is not amiodarone. Amiodarone is a good drug. It can be used. There is no problem in that. But ideal way is rate control. Okay. How do you control the rate?
Beta blockers.
Beta blockers or
calcium channel blockers.
Okay. But amiodarone has got good action on both rate and rhythm control. So amiodarone is also a very good choice. Can be started. But according to ACLS guidelines, beta blockers or calcium channel, they are the first line drugs. Amiodarone is equally effective and equally good. So you can start that also. So you have started amiodarone. What is the dose of amiodarone?
Amiodarone actually first we'll be giving 150 mg stat, followed by 1 mg per kg for 6 hours, followed by 0.5 mg per kg for 18 hours. And then we can change to like oral medication like
injection also available 100 milligram. You can give if the patient is not able to take injection or tablet. So then how you continue that? 100 milligram.
100 milligram
BD or TID. Then slowly you can taper down and BD, OD dose can be given. Okay, but this patient may require longer therapy. Okay, what happened to this patient afterwards? How long you continue infective endocarditis treatment?
4 to 6 weeks.
4 to 6 weeks. Okay. How do you confirm that patient has improved?
We can do
what happened to the culture?
Cultures were negative.
Negative. Okay. Culture negative infective.
Culture negative infective endocarditis.
What is Marantus endocarditis? Marantus. Where will you get? Should know all these things. There is no relaxer. Exams they will ask all these things. What is Marantus endocarditis? Marantus endocarditis is a type of non-infective endocarditis, especially in SLE and all. Female patient SLE, they develop infective endocarditis. Okay, so that is not very common. SLE is, itself is very rare, but in that patient sometimes can present with endocarditis. They are culture negative. So where all you get culture negative endocarditis? One is this non-infective causes. Other thing. All culture negative endocarditis are not non-infective. Sometimes somebody might have treated the patient already, so you get prior antibiotics was given, so it can be negative. Fungus. Fungal infective endocarditis can sometimes produce culture negative, but not very common. Patients who are immunosuppressed, they can develop. Okay. Anything else you want to tell about infective endocarditis? What is Duke's criteria?
Duke's criteria actually major criteria, minor criteria is there. So major criteria pathologic and pathology criteria and imaging criteria was there. Pathology criteria involves like 2 blood cultures will be positive, or like PCR we can get for Coxiella or IgM is positive. And then imaging wise, any like echo or like cardiac CT or PET CT, any one showing vegetation. And then minor criteria, it includes like any prior IE history or like like any cardiac lesions already there, and then like along with that fever, and then immunologic phenomena like that rod spots, Janvey lesions, anything was there, and then like prior surgeries, cardiac surgeries and all. So like if like two major criteria fulfilling, or one major and 3 minor or 5 minor criteria, then we'll call it like definite
There is
eye
something about prosthetic valve endocarditis.
prosthetic valve like.
We have a patient in ICU now, right now. Aortic valve replacement. She has come with fever, with chills and rigors. What are the organisms? How do they present? What are the
Common
complications?
organisms will be like Staph aureus, Streptococcus viridans, and has a group of organisms, and then Enterococcus also, and then complications will be like heart failure or like any septic emboli. It will lead to septic emboli.
This is the most dangerous form of heart failure in with this valve replacement. Stick valve. Stick valve is the most dangerous because we cannot do anything. Sometimes patient may die. Okay, stick valve infective endocarditis. You have to patient will be very sick. Okay, so that can happen sometimes. And how do you know that infective endocarditis is affecting a replaced valve? Clinically, how do you know? Any patient who is having fever with chills and rigors, we are going to do echo. Okay. If we are not getting transthoracic echo, we have to ask for transesophageal because that is the first suspicion. But clinically, how do you check? How do you suspect?
Like patient, if after post-surgery, patient if presenting with fever, that to evening rise of temperature with chills.
We can get so many conditions.
Chills.
Auscultation for?
Sound
of the replaced valve. So if you are very like you know about replaced valve sounds, okay, different valves will produce different type of sound. If you already know that, and if you auscultate, you are not getting that sound, you have to always suspect infective endocarditis. Otherwise, other clinical findings you already told that has to be. But any replaced valve patient coming with fever, chills, and rigors, first differential diagnosis is always infective endocarditis. Then only other things will come. Okay, what is subacute infective endocarditis?
Duration.
Subacute. Acute, like fever with high degree fever, chills, rigors, what we have patient in ICU is acute. Subacute means very low grade fever. It takes longer period. Okay, organisms may be same, but the duration is longer. That's all. Some organism may change. That's all. Okay. What are the complications of infective endocarditis?
Heart failure, stroke.
Now we told one problem. Cardiac failure. Patient will go to cardiac failure and leaky valves. So many things can happen. Okay. Now you have to tell me about infective endocarditis prophylaxis. That is very important because we are not going to do any valve replacement. We are not going to do all these things. But patient will come to you for valve infective endocarditis prophylaxis. Here the prophylaxis was not given appropriately. That may be the reason. So tell me about infective endocarditis prophylaxis. So that is the most important thing we are supposed to know. In emergency room, we are putting a catheter, any dental procedures, post-trauma. We have to give one dose of antibiotic. Whatever happens, we have to give one dose of antibiotic. What antibiotic you give? It is very simple. All above diaphragm procedure you are doing, you cover with a gram-positive antibiotic. All below diaphragm coverage, you give a gram-negative coverage. Almost all cardiac lesions are prone to develop infective endocarditis, except ASD and some mild mitral stenosis. Sometimes you can see bicuspid aortic valve. That will be an innocent lesion. If you see the patient, they'll have a mild aortic murmur, all these things. But they are also prone for infective endocarditis. So if you are hearing any murmur in any patient, give an antibiotic dose prior to any procedure you do. But nowadays what they are telling is catheterization may not require infective endocarditis, but we will not be able to take risk in our country. But that all for foreign countries where antibiotic usage is restricted. But here it is very difficult. Most of these patients will come back like this. You have to be very careful. Infective endocarditis prophylaxis is a mandatory thing we all should know. Any procedure, whatever we do. Okay. Anything you want to tell? Nothing. Thank you.